Assalamu alaikum students. Today the topic of our discussion is myocardial infarction, and we will discuss this topic in two lectures, and this is the first lecture on myocardial infarction. These are our learning outcomes, and up to the complications of MI. This is first lecture, and from discuss what happens in infarcted area. From there we start the second lecture on MI. So firstly we start with the definition, and then etiology, then types, then pathophysiology, clinical manifestations, and complications of MI. Today we will discuss these topics. So first of all, myocardial infarction, first of all its definition, overall process in which area of cardiac muscle has either zero flow or so little flow due to atherosclerosis and occlusion of coronary artery by an embolus or thrombus that it cannot sustain cardiac muscle function. So the blood supply is either zero or so little that the cardiac muscle cannot sustain its function, and this is due to either atherosclerosis or occlusion of coronary artery by an embolus or thrombus. You have studied about the atherosclerosis, that is the plaque formation due to cholesterol, and the area of cardiac muscle is called infarct. The process is infarction, and the area is infarct. You can see here the cholesterol plaque, and in the heart you can see also in blue color, in purple color, the dead muscle that is beyond the cholesterol plaque or the thrombus. And the etiology, very simple, non-modifiable risk factors and modifiable risk factors. Modifiable risk factors are that which cannot be corrected and cannot be modified. These include age, gender, and female history, family history. And modifiable risk factors: stress, smoking, sedentary lifestyle, obesity, alcohol intake, hypertension, drug abuse, diabetes, chronic kidney disease, and this is the list of modifiable risk factors. And the types of infarct or the types of myocardial infarction. Firstly, according to anatomical region of left ventricle, that is anterior wall, posterior wall, lateral wall, septal, circumferential, and combinations that are anterolateral, posteriolateral, and anterioseptal. So there are total 6 types of infarct on the basis of anatomical region of left ventricle. And depends on the thickness of left ventricle, transmural and laminar. Transmural is of full thickness of the left ventricle wall, and laminar is only restricted to subendocardial region. And the other name of transmural is ST elevation MI, STEMI, and laminar, the other name is NSTEMI, non-ST elevation MI. We will discuss it in further slides. According to age of infarct, newly formed, and advanced infarct, that is old infarct. We will discuss the first point, that is anatomical region of left ventricle, in detail. Second also in detail. And there is also the fourth classification, that is according to duration. According to duration of the infarct. So we will discuss all these 4 types. Firstly, the anatomical region of left ventricle. You can see here these are the leads of ECG, and these leads of ECG show the area of heart. Each lead depicts different area of the heart. As you can see here, the lead 1 shows the lateral part of the ventricle. You can also see here left ventricle, its lateral wall 1, and AVL and V5 and V6. These leads depict lateral wall of the left ventricle, while 2 lead, 3 lead and AVF lead depicts inferior wall. You can see here the and V1, V2 depicts the septal region of the ventricle, and V3 and V4 depicts anterior wall. So these are the portions. You can also see in the coming slide like this. Anterior wall MI, V3 and V4 has ST elevation. And the artery involved here is left anterior descending artery. You can see here the coronary arteries, left anterior descending artery. And in reciprocal ST elevation, actually the reciprocal means that in the leads, few leads have ST elevation and a few leads have ST depression, and the leads on the area in front of the infarct shows ST elevation, while the area opposite to the infarct shows ST depression. So the area that is anterior wall, that it has V3 and V4 having ST elevation, while 2, 3 AVF has reciprocal ST depression. This is the characteristic of ECG in anterior wall MI. And the lateral wall 1 AVL V5 V6. You can see here 1 AVL V5 V6. This is lateral wall. You can also correspond here 1 AVL V5 V6 ST elevation, and its corresponding reciprocal ST depression in 2, 3 AVF. So it is you should only know about the ST elevation and which artery is involved in the respective type of MI. Okay, and inferior wall 2, 3 AVF, 2, 3 AVF region, and this region is supplied by right coronary artery 80% and right circumflex artery 20%, while lateral MI left circumflex artery is supplied by left circumflex artery, and posterior wall MI is the true MI, and this area is involved by right circumflex artery, while septal MI, ST elevation, Q wave formation. I will tell you about the Q wave formation in the coming slides, how the Q wave is formed, and the T wave inversion in leads V2 and V3, and the left anterior descending artery and the septal branch of left anterior descending artery is involved. You can see also here the septal area V1, V2, And then there is a combination of MI, anterior-septal MI, anterior-lateral MI, and anterior-septal MI includes V1 to V4, as you see in anterior V3 and V4, and in septal V2 and V3. So when we combine both of these anterior and septal MI, the leads we get are V2 to V4. So mainly involved in septal MI leads are V2 and V4. And in anterior lateral, you can see here this is the combination of anterior and lateral MI. So the leads of anterior and lateral MI are involved here. One AVL and V3 to V6, because it is the combination of anterior and lateral MI. And then subendocardial MI, symmetric T inversion in all chest leads, no Q wave. And transmural Q wave MI, no ST changes. And then there is also a atrial MI, PR segment in 1, V5 and V6. And this is the right coronary arteries involved here. So you should focus on the ST elevation changes during each type of MI and the coronary artery, which coronary artery is involved. Leave the reciprocal ST depression at your level. And then STEMI and then NSTEMI, ST elevation MI and non-ST elevation MI. ST segment is elevated in STEMI, and in non-STEMI, the name indicates ST segment depression is there. T-wave changes are also there, either inversion or tall T waves may be there. Q wave development in STEMI, and no Q wave development. I will discuss it in the coming slides, but how the Q wave develops. Cardiac enzymes elevated, mild cardiac enzymes elevated. These cardiac enzymes are also discussed in the diagnosis of the MI. And then there is a reciprocals and no reciprocals. Reciprocals, I have also told you that the reciprocal means that in a few leads there is a ECG, there is a ST elevation, and in other corresponding leads there is a ST depression. So this is the sign of STEMI, ST elevation MI, and this is not found in non-ST elevation MI. And what is the importance of reciprocal? Firstly, it is important in the diagnosis of STEMI, and other is this is also present in very high risk patients. The ST elevation patients are very high risk, and the reciprocals, when we see reciprocals in the ECG, we can indicate that this patient is on high risk. You can also see here STEMI and non-STEMI. First diagram is normal ECG, then STEMI. You can see here the ST elevation is there is a ST segment elevated. This is, you can see here the ST segment is on the higher side, while this is the isoelectric point and how much ST segment is elevated. And in the third diagram there is a ST depression. This is the non-ST elevation MI. And in the fourth slide there is a T-wave inversion, and this is also the NSTEMI. So two diagrams of NSTEMI and one is Venn diagram. Second number is of STEMI. Now we will discuss according to duration. This is the fourth classification, or the fourth type of MI or infarct. Hyperacute phase within minutes, lead facing the infarcted surface ST segment elevation, lead facing the uninjured surface ST segment depression, T wave tall and widened, but in hypokalemia tall and narrowed, and R wave increased amplitude, Q wave absent, T wave tall because in injury of myocardium potassium are released. And so in the hyperacute phase, this is the first phase of MI, the T waves are tall because of the increase in the release of potassium by the injured myocardium. No infarction and necrosis occurs, so if treated properly, blood supply can be revived. So this state can be reversed if treated properly. But after this, infarction and necrosis will occur. That is the second fully evolved phase with an ORS. Onset of infarction, there is infarction. In first, no infarction. So development of pathological Q wave shows necrosis, attenuation of R wave amplitude, the R wave amplitude decreases, T wave inversion. This is myocardial ischemia. There is a inverted T wave. I will show you in the diagram in the next slide. Resolution phase after weeks old, ST segment comes to isoelectric point, T wave becomes normal gradually, and this is the last change, and the pathological Q wave persists. As the pathological Q wave indicates that there is old MI in the patient. You can see here. You can see how the T waves are tall. These are tall tented T waves because of the release of potassium from the myocardium. And there is also, you can see the ST elevation. This is the hyperacute phase. First diagram is of hyperacute phase, and the second is of a fully evolved phase, where there is also Q wave there. I will show you in the third diagram how the Q wave forms. You can see here. Firstly normal, then hyperacute, then acute phase, ST elevation. This is the isoelectric point. This is the isoelectric point, but the segment is elevated. And in the third diagram, ST elevation, R wave, and Q wave begins. Q wave is this is the Q wave. This notch is the Q wave. So you can see in the fourth diagram, the Q wave becomes deeper. And in the fifth diagram, you can see that, and then also in the fourth diagram, there is a T wave inversion. Firstly, there is a T wave on the upper side, then T wave on the lower side. And after weeks, ST segment and T wave become normal, but the Q wave persists. This is the Q wave. This is the Q wave. This is the Q wave. So the Q wave persists, which indicates that there is older MI changes. And then the pathophysiology, that is very simple. Atherosclerosis, arterial spasm, and thrombus there, and because of all these, there is obstruction, occlusion, and in the blood flow, and then there is ischemia of the heart, and hypoxia, reduced oxygen demand, and even thrombolysis. If thrombus remains permanent, there is necrosis, and then there is myocardial infarction. So the necrosis occurs in firstly in the hyperacute phase. There is no necrosis or infarction, but when there is fully evolved phase, then infarction occurs, and then there is a necrosis. So if infarction and necrosis occurs, then the myocardial infarction will occur. Or if at the acute phase, hyperacute phase, if treated properly, then the worst condition can be prevented. These are the clinical manifestations: chest pain, dyspnea, fatigue. There is an increased respiratory rate due to difficulty in breathing, increased sweating, weakness, nausea, vomiting, lightheadedness, palpitations, anxiety, hypertension, or there may be hypotension, sleeplessness, and the chest pain may be referred to left shoulder. These are the clinical manifestations. Because why to the left shoulder, pain referred to the left shoulder? Because of the same dermatome. Then complications: pericarditis, arrhythmias, congestive heart failure, thromboembolism, rupture of heart, cardiac aneurysm. These are the complications. And this is the second part, which we will discuss in the next lecture.